Alrighty, look like we are at the quorum right now. Welcome everybody to our May DUR board meeting. As a few reminder for our meeting today, if you are dialing via telephone, Google Meet has muted you. If you need to speak to the group, please press *6 on your phone to unmute and mute. We are kindly ask that only those who are speaking to the group unmute their device via Google Meet. For the DUR board member, please reserve your question until the end of presentation or ask in the Google Meet chat. Public comment, if you would like to provide a public comment, a conflict of interest must be on file. Please send an email to medicaidpharmacy@utah.gov. Attendees that are not member of the DUR board, please enter your contact information in the Google Meet chat or send an email to medicaidpharmacy@utah.gov. Please use the chat on the right if needed. And please provide normative feedback after the meeting to help us improve our process moving forward. Thank you very much. And Dr. Cannon, I will leave it to you.
Thank you, Moon. I'd like to welcome everybody out this morning. Let's get things kicked off and get moving. The first thing we have on the agenda is approval of the previous minutes. The board should have received the previous minutes in an email from noon, I guess late last week or mid last week. So for the board, are there any questions about the minutes that were sent out? All right, good 8 seconds. There we go. Anything that needs to be changed on the minutes? All right, hearing none. Do I have a motion to approve?
Eric, I'll motion we approve the minutes.
Thanks, Neil. Do we have a second?
Second.
Thank you, Sharon. All right, all in favor?
Aye.
Aye. Any opposed? All right, minutes from the last meeting are approved. Noon, do we have anything in terms of housekeeping we need to cover?
Yes, Jen will give us an update.
Hi, good morning, everyone. Sorry I'm not on camera at the moment, but I'm commuting in here in just a second. So a couple updates I wanted to share with the board today that are pharmacy related. And these are actually activities that are coming out of this past legislative session, and wanted to update you on where we are with some of our work. So specifically, there are two areas of funding that impacted pharmacy that we want to address. One is our MTM services. So medication therapy management was funded so that pharmacists could bill for cognitive services that are MTM related. And this actually is, the policy is being designed right now internally. It is just about ready for external stakeholder input, and then we will bring it to the DUR board for review. What this is looking at is individuals with chronic conditions. So our typical MTM is going to target individuals with chronic conditions, and we're looking specifically at co-occurring behavioral health and physical health conditions, them receiving an MTM consult and documentation, of course, on the side of the pharmacist, as well as sending something to the member as well as to the provider that would document that service, and then and subsequent follow-up if warranted. So that is a step ahead for our Medicaid program to be able to provide these services and also be able to reimburse pharmacists for these activities. So our next step in the process is to work collectively with our ACO partners in Medicaid to kind of refine this policy before bringing it to you and then going live with it on July 1st. Are there any questions about MTM services?
Does that include chronic pain? Sorry.
Yeah, it certainly could. I mean, I don't know how prescriptive we're going to be with chronic conditions, if it's going to be, and this is part of our policy work of defining exactly like categories of chronic conditions, but certainly it would include chronic pain. So
thank you.
Yeah, you're welcome. Okay. Second update is our diabetes prevention program. So this is a service that was also funded for individuals who are pre-diabetic to be enrolled in a certified program, CDC recognized National Diabetes Prevention Program, that would allow an individual with pre-diabetes to receive counseling, coaching, educational services in a group setting. There are two specific codes we'll look at. One is an in-person code, and another is a virtual option that would allow this service to be delivered to qualifying individuals. This will also be delivered to both fee-for-service as well as ACO Medicaid members. And that policy is also just about in its final phase of internal drafting before we bring it out for stakeholder review and bring it in for public comment from you guys as well. So that is more to come. I think maybe next meeting we'll have those pretty much ready to go. And those are the two updates I had around policy. The next thing is we are posting a pharmacy director position. So I still am in the pharmacy director role at this time, and that position should be posted in the next couple of weeks. So we will be doing a recruitment for that over 2 weeks. And so if you know anyone who's interested, or if you are interested in serving in this capacity, we'd love for you to apply. I think those are our updates from our site. So any questions from anyone?
All right,
Okay.
thank you, Jennifer.
Yeah,
We
you're
appreciate the updates, and I think it's really exciting to see the department moving ahead with MTM and other services that I think will really benefit the members that are the people receiving care through Medicaid in the state of Utah. So thank you.
Yeah, you're welcome.
That's very good work. Let's move on. We have a review now of Tezspire, or Tezepelumab, and we'll turn that over to the University of Utah.
Okay, sounds good. I'll go ahead and present my slides. Okay, everyone should be able to see those slides now. Good morning. Today I will be reviewing Tezepelumab, a recently FDA-approved monoclonal antibody for the treatment of severe asthma. Asthma is a complex, heterogeneous respiratory disease usually characterized by chronic inflammation that causes breathing difficulties due to narrowing of the airways. Asthma severity varies from mild to severe depending on the frequency of respiratory symptoms and exacerbations. Although severe asthma constitutes a fewer than 5 to 10% of all asthma diagnoses, it represents a disproportionate fraction of healthcare expenditures among asthma patients. A Canadian study showed that severe uncontrolled asthma approximately contributed to more than 60% of total asthma expenditures. Severe asthma also contributes to a significant symptomatic burden that causes a reduced quality of life due to sleep disturbances, difficulty with physical activity, and daily limitations in the ability to work or function. There are two main categories of severe asthma inflammatory phenotypes that we will talk about: non-type 2 and type 2, also referred to as low T2 and high T2 respectively. An estimated 50 to 70% of asthmatics have the type 2 inflammatory phenotype, with higher percentages expected in patients with severe asthma. Type 2 inflammation is caused by a subset of CD4 positive T cells referred to as T helper 2 cells that trigger type 2 immunity via the adaptive immune system, ultimately resulting in increased levels of IgE and eosinophils. Additionally, type 2 inflammation may be stimulated via the innate immune system by bacteria, viruses, and irritants that promote the production of thymic stromal lymphopoietin, abbreviated TSLP, by respiratory epithelial cells. Evidence suggests TSLP is also involved in other non-type 2 processes associated with asthma, such as promoting neutrophil-mediated airway inflammation or stimulating changes in structural cells of the airway. Type 2 inflammation is generally identified by one or more of the following indicators at the initial assessment: increased blood eosinophils, increased fractional exhaled nitric oxide concentration, sputum eosinophils greater than or equal to 2%, and signs of allergen-driven asthma. Whereas the non-type 2 phenotype is usually associated with an older age of onset, smoking, obesity, and corticosteroid resistance. Non-type 2 may either have normal sputum eosinophil levels and neutrophils within the normal range, or have elevated neutrophil sputum levels. Of note, concurrent steroid use should be considered when evaluating the presence of non-type 2 asthma, because corticosteroids have the potential to suppress type 2 inflammatory biomarkers below thresholds that differentiate type 2 from non-type 2. Tezepelumab is a first-in-class agent that is a TSLP antagonist, which impacts type 2 inflammation at the outset of the inflammatory pathway, thereby affecting downstream pro-inflammatory pathogenic mechanisms of asthma. Theoretically, tezepelumab could provide benefit for those with non-type 2 asthma. However, the mechanism of action for tezepelumab has not been conclusively determined. It was approved by the FDA in December 2021 as an add-on maintenance treatment of severe asthma in patients 12 years of age and older, regardless of the presence of biomarkers such as eosinophils or allergic positivity. It must be administered by a healthcare provider in a healthcare setting, and it is provided as a subcutaneous injection every 4 weeks. There are 5 other add-on biologic treatments approved for severe asthma with type 2 inflammatory markers. Of note, dupilumab and ocrelizumab are approved for moderate to severe asthma. Dupilumab can also be used for moderate to severe asthma that is dependent on oral corticosteroids, regardless of the presence of biologic markers. These agents target pro-inflammatory cytokines and mediators downstream of the tezepelumab target TSLP. Dupilumab, mepolizumab, and ocrelizumab are approved for a younger age range than tezepelumab. Benralizumab is approved for the same age range as tezepelumab, whereas reslizumab is approved only for adults. All products are administered subcutaneously, except reslizumab, which is administered intravenously. Biologics are typically reserved for patients with difficult to treat or severe asthma. The 2021 guideline for the Global Initiative for Asthma, abbreviated GINA, recommends add-on targeted biologic therapies should be considered for patients experiencing exacerbations or uncontrolled symptoms despite using a high-dose ICS/LABA, and who have allergic or eosinophilic biomarkers or require maintenance oral corticosteroids. NHLBI NAEPP recommends that patients with severe asthma receive at least medium-dose ICS formoterol prior to considering an add-on biologic. Asthma guidelines do not yet incorporate tezepelumab as they were published prior to its approval. The 2021 GINA guideline states that biologic treatment selection is based on phenotypes and other factors such as predictors of asthma response, affordability, and patient preference. 3 pivotal clinical trials, Pathway, Navigator, and Source, evaluated tezepelumab as add-on biologic treatment for severe asthma. The type 2 dose-finding trial, Pathway, suggested positive efficacy and safety of tezepelumab for reducing asthma exacerbation rates when used at 210 milligrams subcutaneously every 4 weeks. This dose was carried forward to the 2 phase 3 RCTs, Navigator and Source, in which tezepelumab was compared to placebo among patients with severe asthma. In both trials, tezepelumab tended to reduce the annualized rate of asthma exacerbations over the treatment duration, but statistical significance differed between trials, with tezepelumab being favored over placebo in Navigator, whereas in Source, no statistical difference was observed. This was the primary endpoint of Navigator and a secondary endpoint of Source. In Source, tezepelumab failed to significantly reduce the daily maintenance oral corticosteroid dose versus placebo. In Navigator and Pathway, the benefit on asthma exacerbation rate favoring tezepelumab was consistently observed regardless of baseline eosinophil concentration or allergic status. Regarding secondary outcomes compared to placebo, tezepelumab improved pulmonary function and patient-reported outcomes related to asthma control or symptoms and quality of life in Navigator and Pathway. Of note, Navigator and Pathway included patients taking medium or high-dose ICS in combination with a LABA or at least one additional controller agent per standard of care. Labeling for tezepelumab includes warning for hypersensitivity reactions, precaution to avoid live attenuated vaccines during tezepelumab use, and the precaution to treat active parasitic worm infections before starting treatment. When starting tezepelumab, the abrupt discontinuation of inhaled or systemic corticosteroids should be avoided to prevent withdrawal symptoms and or manifestation of symptoms from conditions formerly suppressed by corticosteroid treatment. Tezepelumab appeared well tolerated compared to placebo across the 3 studies. The most common adverse events were pharyngitis, arthralgia, and back pain, along with injection site reactions, which occurred more frequently in tezepelumab-treated patients than those receiving placebo. Similar to other biologic proteins, immunogenicity may develop during treatment with tezepelumab, such as anti-drug antibodies, as well as neutralizing antibodies. Utah Medicaid currently has prior authorization or PA criteria in place for tezepelumab, along with the other 5 biologics approved as add-on therapy for asthma. The considerations are consistent with the current PA form for asthma biologics, but additional details specific to tezepelumab are provided. Please refer to page 29 of the report for the complete supporting rationale. PA criteria may include reserving tezepelumab for patients that meet the FDA-approved indication, such as patients with severe asthma that are 12 years of age and older, and prescribed by or in consultation with a pulmonary, immunology, or severe asthma specialist. Additional PA may be written to ensure the medication is administered by a healthcare provider and that the prescriber attests other strategies and factors have already been attempted, addressed, or considered prior to the initiation of tezepelumab, such as inadequate response or intolerability after treatment with a preferred first-line therapy for severe asthma for an appropriate duration per an accepted asthma practice guideline. Considerations with respect to the current PA criteria are provided. Allergen testing, in particular thresholds for baseline eosinophil concentrations, do not necessarily apply for tezepelumab since clinical trials did not require patients to meet certain biological marker thresholds for enrollment. Moreover, in Pathway and Navigator, tezepelumab demonstrated therapeutic benefit in exacerbation reductions compared to placebo in asthma patients, regardless of baseline eosinophils and allergic status. Currently, tezepelumab is listed as a non-preferred product on the Utah Medicaid Preferred Drug List, or PDL. As a PDL non-product, according to the current PA, tezepelumab would be accessible after a 3-month trial and failure of one of the preferred biologics for asthma or based on medical necessity. Since the indications for all the PDL preferred products do not include patients who have non-type 2 severe asthma phenotype, such as non-eosinophilic and non-allergic, and are non-oral corticosteroid dependent, tezepelumab could be considered for this subpopulation without requiring failure of a preferred biologic, since its indication does not require meeting a type 2 related biologic marker threshold. This concludes the presentation. Please let me know if you have any questions. Thank you for your time and attention.
All right. Does anyone on the board have any questions? All right. Hearing none, maybe we will have some more that'll come up here in a minute. But we do have some public comment from Amgen. So, Carrie Johnson, are you on the line?
Yeah, can you hear me?
We can hear
Hello?
you.
Oh, great.
Yeah, we'll turn some time over to you. I think you have 3 minutes. Am I right on that, Brian?
That's correct.
Yes, that's correct.
Okay.
Okay, thank you. I'll go ahead and get started. My name's Carrie Johnson, and I'm a pharmacist with Amgen Medical Affairs. Thank you for the opportunity to speak in support of Tezspire, or tezepelumab. As noted in your review, Tezspire is a first-in-class biologic for severe asthma that acts at the top of the inflammatory cascade by targeting thymic stromal lymphopoietin, TSLP, an epithelial cytokine. Blocking TSLP reduces biomarkers and cytokines associated with inflammation, including blood eosinophils, airway submucosal eosinophils, IgE, fractional exhaled nitric oxide, and IL-5 and IL-13. Tezspire was originally granted FDA breakthrough designation for patients with severe asthma without an eosinophilic phenotype in September of 2018. It was then, as noted in the review, subsequently approved in December 2021 for the add-on maintenance treatment of adult and pediatric patients aged 12 years or older with severe asthma following a priority review by the FDA. Tezspire is not indicated for the relief of acute bronchospasm or status asthmaticus. Please see the full Tezspire prescribing information at amgen.com for further details. As noted in the review, patients with severe uncontrolled asthma represent a small portion of the overall asthma population. However, these patients have a disproportionately high burden of disease. Although other biologics are available, up to 20% of severe asthma patients are ineligible for existing biologic therapies, and approximately 35% of severe asthma patients are uncontrolled. Tezspire represents a novel approach to treating these severe asthma patients. By inhibiting TSLP, an upstream mediator of multiple downstream inflammatory pathways, Tezspire uniquely addresses the heterogeneity of severe asthma. As noted in the review, within the prescribing information, there are 2 key trials named that support the indicated severe asthma population. Both trials are fully published and supplied. Pathway trial was a phase 2 trial that supported breakthrough designation, and Navigator was the pivotal phase 3 trial study that supported priority review status. Both trials were 52-week randomized placebo-controlled trials that were designed to evaluate the effect of Tezspire on asthma exacerbations in patients with severe asthma, as noted in the review. Importantly, there were no restrictions on biomarker status for eligibility. Tezspire demonstrated statistically significant reductions in asthma exacerbations across these 2 key trials, Pathway showing a 71% reduction and Navigator showing a 56% reduction, both statistically significant. Tezspire is the only asthma biologic to demonstrate statistically significant reductions in exacerbations in patients with eosinophil counts less than 300 cells per microliter. The FDA viewed this as a key differentiator, and this supported the breakthrough designation and priority review status. Additionally, the registrational trials demonstrated a reduction in exacerbations, 80% reduction in exacerbations requiring hospitalizations or ER visits, and consistent reductions in exacerbations across phenotypes. From a safety perspective, Tezspire has an adverse event profile similar to that of placebo. Most common adverse events included pharyngitis, arthralgia, and back pain, all showing an incidence rate of 4% compared to all 3 showing a 3% incidence in the placebo groups. In summary, Tezspire is the first and only biologic.
That's time. Thank you.
Okay. Yep. Thank you. Thank you for your time.
All right.
Happy to address any questions.
All right. Does anyone have any questions for Carrie? All right. Hearing none. Noon, why don't we move over to you with the proposed prior authorization criteria?
Thank you. So we propose to use the anti-asthmatic monoclonal antibody, which is also including the criteria for Synquar, Dupixent, Fasenra, Nucala, Tezspire, and Xolair in this combining form. The first criteria is the medication is prescribed by or in consultation with a physician who specializes in the disease treatment. Second is documentation of FDA-approved diagnosis, and if there's any allergen testing, if applicable, and any other confirmation testing. We must use the FDA-approved labeling and any box warning. My apologize, as we are having 2 pages on this PA right now, so it might be hard to see the entire thing. Documentation of appropriate first-line treatment of intervention. If current treatment standard recommend other treatment modality or intervention prior to the use of requested drugs. And since the Tezspire is also a non-refer product, we allow the pathway to receive the non-refer product if there is a minimum 3-month trial and failure of at least 1 refer product in this therapeutic class, or if any of the refer product is not fitting, the prescriber must demonstrate the medical necessity for the non-refer product. We also allow the pathway for having an off-label or compendia use of any of these products as well. We require the re-auth criteria have the updated letter with medical justification or updated chart note demonstrating positive clinical outcome. The initial authorization will be up to 6-month approval, and the re-auth will be up to 1-year approval. In the note section is how to build it on the as a medical product on the medical side. Let me show this criteria. I'm trying to show both sides.
I think there's a view option to show them side by side, but it might be too small to see on this screen. Yeah. Thank you.
Would this help?
Yeah. Is that all the pages?
Yes.
Great. Great. Thank you.
And for the utilization perspective, we have 0 patient on the Tezspire right now.
Noon, do you know how many patients are on the other 5 products?
That's a good question. I can tell you immediately. We also have 0 patient on Nucala. We have 4 patient on Xolair, 1 patient on Fasenra, and for Dupixent, we have Dupixent is our most utilized medication. We have around 23 patients on Dupixent.
Great, thank you. I think that helps us understand the size of the population. Any questions or proposed thoughts on the criteria as presented?
Noon, question for the pharmacy team. How's this form been working out in the past for the other products? Anything seem to be missing from the pharmacy team, or has it been working out and meeting the needs?
That's a good question, Neil. Thank you. So we have been revised this form multiple times to accommodate all of the anti-monoclonal antibody has been coming out to the market. We used to have the table that indicate on the indication of these products, and the form has getting kind of hard to manage. That is when we decided to kind of put this way to the form where we can accommodate all of the that will make when we review, we have to look in back up the PI and follow exactly what the PI has to review the prior authorization. So the form has been published for a few months, and I think it has been pretty okay with us.
Okay. Thank you.
I would
All right.
I would just comment if I may, Eric, this is Dr. Weinstein, and thank the Amgen representative for just highlighting those details from the product. This is an area that's not my clinical area, but this whole category of treatment is clearly a step forward in the treatment for these patients who do represent a small population, but those who have much more severe disease, and it looks like a real progress in their treatment. So these products haven't been on the market that long, what I gather, and we have a small number of patients, but they would be in need of this treatment. So I think if we've got the form structured so that it gets those patients who are eligible to the right therapy, and it's designed appropriately. I certainly don't have the clinical expertise to make any other contribution. I thank the pharmacy team for that excellent review, and I would propose we approve this as written unless anybody else has any other comments.
Well, we have a motion to approve. Do we have a second?
Second.
Thanks, Catherine. We have a second. All in favor?
Aye.
Aye. Any opposed? All right, we will move ahead with this criteria. Noon, I think the one thing that might be good for this committee is in maybe a year, if you all could come back and help us understand better what are the utilization patterns you're starting to see, who are the patients, and how has it been working for them. I mean, I don't know that it needs to be real long, but I think it would help this group to see, as this is a growing category, as this will be an increasing expense for the state, it'd be good to understand what are those utilization patterns sometime in the future. So
Yes, I can put this out for like a 1-year review that we can go back and review this for next year. Thank you very much for your recommendation.
all right, Louis, we'll turn it over to you, and I'm not even going to try and say it because I get it wrong. So in terms of the next item on our agenda, help Leo's.
All right, perfect. Thank you. Thank you, Eric. So can everybody see this presentation so far? Okay,
Yes, thank you.
Cassie Meltion, Hetlioz. So I'll be talking a little bit about this medication, and let me see here if I can get, all right. So there we go. There's the agenda. First, I want to talk a little bit about the normal circadian rhythms, and then go into the medication details, MOA, studies, place in therapy, and all of that. So with the normal circadian rhythms, the endogenous circadian rhythms are regulated by the suprachiasmatic nucleus, or the SCN, in the hypothalamus. Circadian rhythms are usually longer than 24 hours in most people. Thus, they require daily synchronization or entrainment. That's the actual medical term, entrainment, to align with the 24-hour environment. The primary means to keep the SCN clock entrained is via light-dark exposure through specialized cells in the retina of the eye called retinal ganglion cells. And the SCN, it's also involved in hormone production, regulation, metabolic regulation, body temperature cycle, and the sleep-wake cycle. And it regulates the production and release of melatonin from the pineal gland. And in healthy subjects, melatonin levels are elevated at night to help the person sleep, and remain low during the day to help the person stay awake and alert. So now talking about Hetlioz, tasimelteon. It is a melatonin receptor agonist at the MT1 and MT2 receptors. Tasimelteon has greater affinity for the MT2 receptor, which is thought to be more involved with regulation of circadian rhythms. The MT1 receptor is more involved with initiate the start of sleep, to get someone to start sleeping. Drug effect may not occur for weeks or months, is one thing that I noted in the PI. And on the right side, we have a little table here talking about the different indications for this drug, one being non-24 disorder. And for that, we have the 20 milligram capsules that are indicated for adults. And then also the second indication is nighttime sleep disturbances in Smith-Magelis syndrome. And that one, we have the capsules, 20 milligram capsules for individuals 16 years of age and older, once a day, 1 hour before bedtime. And then also the indication is also for children ages 3 to 15 years old. And for that, we have the oral suspension with the indicated dosing there. Okay. And so first, let's talk about the non-24-hour sleep-wake disorder, or non-24. It is a rare circadian rhythm disorder in which the patient experiences constant shifts or delays in the sleep-wake cycle. And remember how in normal individuals, we have a cycle that it's a little bit longer than 24 hours. And so through light and darkness, we're able to correct that each day. But in individuals who are totally blind, lacking light perception, we get this non-24 disorder, which affects 55 to 70% of these individuals. It can also occur in sighted individuals with impairment in the circadian response to light. Okay. So now let's talk about the SET and RESET clinical trials. So these are clinical trials conducted by Vanda Pharmaceuticals, which is the manufacturer of Hetlioz. SET stands for Safety and Efficacy of Tasimelteon, and RESET stands for Randomized Withdrawal Study of the Safety and Efficacy of Tasimelteon. And so we have the criteria, inclusion criteria for the SET study, which did include subjects that had total blindness and complete absence of light perception. And the circadian rhythm was longer than 24 hours in these patients, and they were not taking sedatives or stimulant CNS active drugs. And they were randomized to receive 20 milligram capsule daily of tasimelteon or placebo. And the duration was 6 months. Primary endpoint was proportion of entrained patients at 1 month. For the RESET trial, there was a treatment run-in of 11 weeks with tasimelteon, which included patients that were already in the SET trial, and then others. And these patients also had a circadian period of greater than or equal to 24.1 hours in the run-in phase. And so after those 11 weeks, the patients were randomized to the withdrawal phase, which continued, which had two groups. One group continued tasimelteon or received placebo for 8 weeks. And so patients were eligible for this phase if their circadian rhythm period was considered entrained or synchronized, being less than or equal to 24.1 hours. The primary endpoint of this study was the proportion of non-entrained patients from weeks 4 to 7. So the study wanted to see if what was the impact of withdrawing the patient from this medication on their circadian rhythm. And now let's talk about the efficacy. So for the first trial, the SET trial, we have a primary endpoint that was met. And we saw that 20% of patients in the tasimelteon group became entrained versus only 3% of patients in the placebo group. And that was statistically significant. And then also there was a sensitivity analysis where tasimelteon decreased daytime sleep duration by 49 minutes compared to placebo, which was 22 minutes. And that was statistically significant. And as I read some other studies with melatonin itself, that was very similar in terms of the sensitivity analysis, where melatonin was able to also decrease daytime sleep by around a difference of about 30 minutes compared to placebo. For the RESET trial, the primary endpoint, so 90% of patients in the tasimelteon group maintained entrainment as they continued the drug versus 20% of patients in the placebo group that maintained entrainment. And that was significant. Also, patients continuing this drug had about one more nighttime sleep per day, 1 more hour of nighttime sleep per day, and about 1 hour less daytime sleep per day during the worst quartiles of treatment days. Okay, now in terms of safety, these are the main side effects here: headache, increase ALT in the liver, nightmares, urinary tract infections, and then upper respiratory tract infections. The adverse reactions were similar in patients treated with for non-24 and in patients treated with the other condition, which is the Smith-Magenis syndrome, sleep disturbances. But we'll go into that a little bit later. In terms of drug interactions, they are listed there. There's strong CYP1A2 inhibitors that can increase the level of tasimelteon, increasing the risk of ADRs. And then on the opposite side, with the CYP3A4 inducers, they can decrease exposure of this drug, leading to reduced efficacy. Beta blockers are also thought to lower the production of melatonin via inhibition of the beta-1 receptor, leading to reduced efficacy of tasimelteon. And then other benzodiazepine and non-benzodiazepine hypnotics may also enhance sedative effects of tasimelteon. Additionally, exposure to tasimelteon decreased in smokers by 40% compared to non-smokers, given that smoking induces CYP1A2. So now let's talk about a little bit about the other indication here, being nighttime sleep disturbances in Smith-Magenis syndrome, SMS. So SMS is a developmental disorder with 90% of cases caused by a deletion in chromosome 17p11.2, and the remainder of the cases result from mutations in the retinoic acid-induced 1 RA1 gene. And in this case, sleep disturbances are due to an inverted circadian rhythm where melatonin rises during the day and falls during the night. And so patients tend to sleep more during the day and have a hard time with insomnia at night. In terms of efficacy of this drug in SMS, there was a trial conducted by the company, by Venda Pharmaceuticals, where it was a 4-week crossover study, which evaluated the effects of tasimelteon versus placebo on sleep disturbances in patients 3 years to 65 years of age with SMS. And the total population was 25. And Tasimelteon met the primary endpoint of improvement in the 50% worse sleep quality. And also it significantly improved the overall total nighttime sleep duration, which was 41 minutes in the Tasimelteon group versus 20 minutes in the placebo. And that was thought to be significant. In terms of place in therapy, guidelines do recommend melatonin as being the mainstay for non-24 in blind patients, blind adults. And then also for the sleep disturbances in SMS, melatonin is also recommended. And then as second line, if you will, melatonin agonist. So tasimelteon is one. And to help those patients that can't tolerate melatonin or where melatonin didn't work for them. And that's in the American Academy of Sleep Medicine guidelines in terms of the recommendation for melatonin. Unfortunately, the updated guidelines in 2015 did not include recommendations of melatonin because it had been recently approved, so it didn't make it in the guidelines. So now we have the PA statistics for Utah Medicaid. And so there were 6 prior authorizations submitted in the period of 5/1/21 to 5/1/2022. And they were all denied. And they were all for the Hetlioz 20 milligram capsule. And the reasons was 1, PA not submitted by a healthcare provider. The PAs had been, 5 of them had been submitted by the manufacturer. And then 1 was missing required documentation from the healthcare provider. All right, so now I'm going to stop. Or actually, are there any questions about this presentation before I go into the PA, the new PA form?
I have a question.
Yes.
Do you know how many people dropped out of the trials due to side effects or adverse effects?
Yeah, so I believe there were 6 people that dropped out of the set trial for the Tasimelteon group, and then 4 people in the placebo group. And but the reasons for dropping out were not tied to side effects of the drugs. And so that wasn't a concern in terms of for the side effect aspect.
Great, thank you.
No problem.
Louis, so the first trial was done in people that had complete absence of light. Was reset, I'm assuming, the same population since it was a continuation. Is that correct?
Exactly. Yes, that's correct.
So the drug has only been studied in those people that are totally blind, no light at all, correct?
Yes, that is correct.
Okay.
So I will go ahead and share the
Luis, I've got a question.
Louis, one more question.
yes.
So was there any requirement that these patients had been on melatonin or something in the past? I noticed that, at the time of the trial, they were on no sedatives or anything at all. Any history? I mean, these are extremely small trials.
Exactly. Yeah. So there was no requirement that they had to have been on a trial of melatonin before enrolling in the trial. They pretty much only had to meet the inclusion criteria of having the condition, and then being totally blind, no
Okay,
light
and
perception at all.
right, and no active comparator. These were complete placebo trials. Am I correct?
Correct. Yes.
Thank you.
I
Yeah,
do believe in those trials, though, they did measure urinary melatonin metabolite prior to, at least for the FC trial, which is not something that most clinicians do on a regular basis. But I believe that was actually part of the efficacy trial, not necessarily the safety trial, as part of diagnosing kind of entrainment.
exactly.
All right.
Yeah. So with the inclusion criteria for the SET trial, they did measure, that's right, the circadian period was calculated using urinary 6-sulfathoxymelatonin, which is a major melatonin metabolite. So that was measured for each of the patients, and it had to be greater than 24.1 hours in order to be considered non-entrained or non-synchronized and to be part of the trial. Yes, that's correct.
Excuse me, to just clarify, Dr. Siegfried and Luis, that's an endogenous metabolite.
Correct.
Thank you.
Yes.
Mhm.
Luis, do you know if melatonin or Ramelteon has ever been studied for non-24?
Yes, yes, melatonin has, and it has been successful at helping patients become entrained again or synchronized in non-24. And like I mentioned before, in the SET trial, there was a difference of about 30 minutes in the patients that were able to sleep sleep better during the night and less during the day. So patients that were taking this drug Helios compared to placebo were able to sleep for about 30 minutes additionally each night compared to placebo. And then studies that I read with melatonin, they showed similar results as well.
I also believe the 2015 American Academy of Sleep Medicine guidelines did recommend the use of melatonin, although I think the evidence was fairly weak. And as Luis said, they did not include the Tasmelteon. So
Exactly, because just the timing of approval of the drug and all of that. So,
Luis, it's Joe. What about the second part of Brian's question on the other I'm drawing blank,
Ramelteon.
Ramelteon. There we go. Thank you, Brian.
okay, no, good. Yeah, with Ramelteon being another melatonin agonist affecting the MT1, MT2 receptors, there's no studies that I'm aware of in these for these indications being non-24 or the SMS.
Thank you.
You're welcome.
Louis, on the PAs that have been submitted, have they all been for non-24, or were they in partially sighted or non-sighted individuals? Do we know that?
We don't know because the information that was submitted was, like I said, it wasn't by the provider, it was by the manufacturer. And so I can't remember. I think most of them were non-24. I can't remember there was an SMS one.
My recollection is that every single PA that we have received for Hetlios has been from Vanda with no clinical information whatsoever submitted.
Yeah.
It's interesting.
I think it must have been non-24 because it was for the 20 milligram capsule, which is the one that's indicated in adults.
So the PAs aren't coming from a provider, PA requests not coming from a provider, but from industry specific?
Exactly, on behalf of the patient.
And I think, Neil, the more important piece there was no clinical information submitted.
Exactly. That's
Which-
concerning.
Well,
Well-
certainly on the negative side, that's the industry, pushing the drug. On the other side, there's a busy clinic, and the rep is saying, here, I'll help you out, but it's not acceptable. You can't process that without any clinical information. That's not how we want it to go.
I do think we need the clinical information.
Of
with that.
course, no question. I'm not.
Well, and Sharon, you wouldn't run out and buy a new car without any documentation.
No. I wasn't saying that
And
at
I
all.
can't talk about what it costs, but like I said, you wouldn't buy a new car without something like that.
Not condoning this in the least. I'm just saying I know how this happens.
Yeah. No.
But just for reference,
I'll do it for you, right? And then it's.
but just for reference, we get no other PAs come in from the manufacturer.
Only this company.
I mean, I've had,
Right.
it's been a long time, but historically, I have had company representatives say they would assist me, and I've declined that. But it's been a long time since it's happened with me, but I've seen that happen. It's not generally what we want to occur, but at least they could put something on there. Sorry.
All right, we got 20 minutes, guys, and the goal is to get out early. So let's take a look at the criteria.
All right, thanks, Eric. So yeah, with the PA criteria, this new draft was mainly the aim is to distinguish between the two indications. The last one, they were all kind of jumbled together, but there's now separation of the criteria to make it clearer for the providers. So there's criteria that is mutual for both indications. On the part criteria for approval, all of the following criteria must be met, which includes that the provider be certified to prescribe this medication, and then also that the patient either have a diagnosis of non-24 or the sleep disturbances in the SMS syndrome. Also, the age limit is there, 3 years of age or older for SMS. Symptoms cannot be better explained by another current sleep or other condition. Documentation that behavioral modifications have been implemented, which is really important, the non-medication part of the treatment plan. So we want to know about that. And then this is new here, failure of at least 1 month trial of melatonin or intolerance to melatonin, given that there are trials done with melatonin that report success similar to this medication in terms of both conditions. And so we want them to try that first. And it takes about a month and a half to 2 months. In those trials, it took about a month and a half to 2 months for the patient to become entrained with melatonin use. So, but we're being a little more lenient here, at least 1 month. All right, in terms of the criteria for non-24, so history of insomnia or excessive daytime sleepiness that alternates with time periods of being asymptomatic as the individual rotates between alignment and misalignment. Because with this condition, there's a constant delay in the sleeping pattern, usually by an hour or so each night, where the patient can't sleep as there's a delay. So that's kind of the clinical picture for non-24. And then symptoms documented as being present for at least 3 months. And then daily sleep logs and actigraphy for at least 14 days, demonstrating a gradual daily drift in the rest activity patterns. So that's all part of the diagnostic criteria for this disorder. Additional criteria for SMS, documentation of genetic testing showing a deletion in the chromosome 17 or RAI1 gene mutation, and then history of sleep disturbances. In terms of reauthorization criteria, we want an updated chart notes or letter of medical necessity demonstrating positive clinical response, and also that the provider attests to reviewing HETLIO's adherence goals with the patient at each visit, because obviously this medication, in order for it to work, it has to be taken every day, an hour before going to bed, around the same time each night. So then there also, we have a note here for the provider, which says concomitant use of HETLIOS with the following agents may put the patient at risk of side effects from HETLIOS or a subtherapeutic effect. So just some documentation on the drug-drug interactions there. Any questions?
Yeah, Louis, I mean, in terms of criteria for approval, we've got failure of at least 1 month trial of melatonin. Is that something that we would expect? And the problem here being there's no idea how that compares to the other product, but is that something that 1 month is a sufficient period of time to know if it's going to work or not going to work?
Yeah, I mean, it says at least 1 month, so we are being a little bit more lenient because in the clinical trials that I read, entrainment with melatonin occurred usually around a 2-month time period, sometimes a month and a half, 6 weeks, so I'm not sure if we want to modify that to reflect that or just say at least a month.
No, I think it should reflect the clinical data, and if it's 6 to 8 weeks for retrainment, then that's what it ought to be.
I
At
agree.
least that's
I
my
agree with
opinion.
Yes.
Okay, that sounds reasonable. Yeah.
I have access because of another job and have reviewed a number of different criteria for this medication, and the amount of time they use or require for step through using melatonin varies between 3 and 6 months, depending on the provider for both disorders. And so at least, you might want to consider a 3-month trial. Some of the criteria go as far up as to 6 months, but I would defer to the rest of the committee on determining that.
Dr. Siegfried, you're our expert here. Would you think at least a 3-month trial is acceptable, or would you recommend 6 months here based on your knowledge of the data and the products and the literature?
I would require a minimum of 3 months. I think 1 month is too short a period of time, especially given the pharmacokinetics and pharmacodynamics, both of melatonin and this medication, in terms of the studies that have been previously done with melatonin and with this agent as well.
Eric, I think Val have a question.
Yeah, I was just wondering, is melatonin something that's covered for Medicaid patients? I just didn't know if it was on the OTC list as a covered product or not.
This raises a big question, Valerie, because if we're not prescribing melatonin and we're over the counter, that raises the question of the inconsistency of the over-the-counter products, right? I think we're all aware of the data that show these over-the-counter products have a high variability of content actual melatonin content. And I may explain treatment failures with melatonin. So what is the, what it might be a reason to have people on longer term, therapeutic trials and counseling them about consistency of product use, et cetera, which is a conundrum in the supplement world.
Yeah, and I think, Brian, you were shaking your head that this is not covered. I guess given the current situation here, it would be in the best interest of the state, in my opinion, that we find a way that melatonin be covered, so that we're giving patients access to an inexpensive yet appropriate treatment.
So yeah, that's correct. Melatonin is not covered by Utah Medicaid, and there's a couple of things sort of standing in the way of that coverage. The first is that there's a requirement for Medicaid to cover a drug. It has to be, the manufacturer needs to participate in the Medicaid drug rebate program. And to my knowledge, there are no rebatable melatonin products. The other thing is that for OTCs to be covered, the Utah State Plan, which is a governing document for how Medicaid operates, explicitly specifies what types of OTC products can be covered by Utah Medicaid, and it's very specific. Like antihistamines can be covered, and then we can choose which ones to cover or not cover. Sleep aids is not one of those OTC categories, and so it would also require an amendment to the state plan, as well as additional steps to be taken to cover something that doesn't meet the CMS definition of a covered outpatient drug. And along these same lines is similar is, internally we had talked about, melatonin receptor agonists in general. And the problem with that, of course, is that there's not the studies for Ramelteon would be the other one which is covered.
I think we are in the process of.
Who modifies that plan, Brian?
It's an involved process that it's usually initiated by someone within the Department of Health, and it goes through an extensive review process and is ultimately approved by CMS. I've been involved in state plan amendments before. It's something that does happen. It's not a quick and easy process.
Okay. I can think of 276,000 reasons why we might want to have you guys go through that process, or at least propose it. But Jennifer, did you have a comment?
Yeah, Eric, I'd like to say I'd love to hear the board's thoughts on this, because frankly, it's something we've thought about, and many other states are covering melatonin. So I actually would love to hear the board's thoughts on the use of melatonin and coverage of it, and whether or not that's something the board would recommend us looking at.
My personal opinion is something that basically I would think that that's something you definitely want to look at. And not just because of this category, but I think you've also got, you tend to have patients get in situations with overuse of Zolpidem or other sleep aids, and this is a far safer option, I think, given all of the things that are taking place right now in the community around controlled substances and overuse of controlled substances. And it would be in the best interest of the state, at least in my opinion, that something like this be covered. Sharon, you had a comment?
Yeah, given the approval for the medication therapy, sorry, what is MTM again, management, the education, I would put this in the context of sleep education because there's so much that can be done non-pharmacologically, and it would give us an opportunity to get that education out, and again, to eliminate all those other much less safe pharmacotherapies that are overprescribed. So I think it's an opportunity to provide a tremendous service, and I'd be interested in Dr. Siegfried's opinion on this also. Thank you.
Well, I know, although I'm not a child and adolescent psychiatrist, I know the FDA has been looking at compounded melatonin use for children and adolescents with sleep issues. Although I don't necessarily prescribe it because it's difficult to get inpatient. I know that inpatient physicians often will use small doses of melatonin in geriatric patients, especially those that are in nursing facilities or other places where natural light is less available often. And that's a problem, at least in that population, as well as the differences in hormone levels and changes in sleep that naturally occur with aging. But I think it's a timely over-the-counter supplement to at least look at as something to be covered. The question is, do you cover it just across the board? Do you limit it to specific ones that may or may not be regulated by or have been verified by USP? Those questions remain to be answered.
All right, Catherine, you had a question. Neil also popped on camera, which sometimes in my mind means he has something to say. So we literally have 3 minutes, and I think that the state would be very happy with us if we also approve their criteria. So
Yeah.
Catherine, you get a minute. Neil gets a minute.
Gotcha. Yeah, I guess I was going to suggest, I agree with the USP verified melatonin as a way to go. And I think maybe something for this prior auth, maybe we recommend that, a trial of USP verified melatonin be used before approval instead of a hard requirement. That's all.
Okay, Neil?
That was it. I was going with the USP. That would just give us an opportunity to maybe vet some better products for our patients. And I like our change that I still think we should go at least 3 months of a trial of a USP verified melatonin on this PA with the initial changes we talked about.
Sharon's got a thumbs up, so
second that.
We're assuming you made a motion
Okay.
to add USP melatonin, and Sharon seconded that approval.
For
With
3
a
months.
3-month.
A 3-month trial. Okay, Noon, have we got all this down, or Lewis? All in favor?
Aye.
Aye. Any opposed? All right, hearing none, that the criteria is approved. And then Noon, if we could maybe have an update just quickly next month in housekeeping about maybe that process around getting melatonin approved for coverage.
Yes, our next 2-month topic will be surrounding insomnia in pediatric and adult. The DRC will do that review for us, and they will also do a review on melatonin briefly.
Okay.
We will have discussion about that for sure.
All right, timing is excellent. So do we have a motion to adjourn?
I'll move we adjourn.
I second.
All right. 8:29. We're out on time, guys. Hey, thank you. Appreciate it.
Great Memorial Day.
All right.
Thanks, everyone.
Bye, guys.
Bye-bye.
Bye-bye. Thank you.